another academic session. It's a moment of pride and purpose. We are gathered here to celebrate 5 incredible years of medicine, a platform that began with simple idea: make medical education accessible, relatable, and inspiring. And oh, what a journey it has been! From whiteboards to webinars, from doubts to deep dives, Medusane has stood by thousands of medical students and young doctors, guiding them through the struggles of exam and the mystery of case studies and the art of clinical thinking. It hasn't just taught topics. It has created a community where learning is joyful, teaching is passionate, and curiosity is always welcome. And at the heart of this celebration is gratitude to the founders, faculty, student ambassadors, editors, moderators, and every single soul behind the scenes who poured their time, talent, and heart into making medicine what it is today. So, to the Medicine Committee, we thank you for 5 years of consistency, clarity, and commitment, and here to many more. Have you ever stared at an ABG report and felt like it's a code from the Matrix? pH, partial pressure of carbon dioxide, bicarbonate levels, and then at that one moment of panic, is this respiratory or metabolic or both? Well, today is the day to unlock it all. Welcome to our special session, ABG Unlocked, your guide to interpretation. Arterial blood gas is one of the most powerful tools in clinical medicine. In just a few values, it tells us how well a patient is oxygenating, ventilating, and balancing their acids and bases. Whether you are in ER trying to stabilize a crashing patient, in the ICU adjusting a ventilator, or just decoding a puzzling case, ABG interpretation is your superpower. But here's the catch: it's often misunderstood, misread, or feared, which is why we are beyond excited to have us with a master in the art of ABG interpretation, someone who makes us complex concepts feels like common sense. Please join me in welcoming Dr. Athul Francis Sir, MBBS MD Respiratory Medicine, DNP MNAMS EDARM, Fellowship in Allergy and Immunotherapy, Consultant Pulmonologist, Mar Augustine Jubilee Hospital, Edappally. Sir isn't here just to give a lecture. He is here to take us on a clinical journey, walking us through real life case studies, challenging our thinking, and helping us look at ABG reports not with fear but with confidence and clarity. I request our beloved Dr. Raghunandan Sir, the founder and chairman Medicine, to invite the guest speaker.
Thank you so much, Lalitha. And I'm very happy to invite Dr. Athul Francis, sir, renowned pulmonologist, and also a faculty of medicine in various coaching institutes, who has been mentoring a lot of students. And today, we have gathered here for Medmemorate 25. Medmemorate 25 stands with the idea to promote the skill development among the medical students, those who are coming out of the medical colleges after graduating. They should be strong enough to practice as a general practitioner. So with this idea, we had come forward with various topics, including ECG interpretation, ABG interpretation, and a variety of topics. And today, I think Dr. Atul sir will give a brief idea about the ABG interpretation, which every general practitioner must to know. Thank you so much, sir, for joining with us. And I hand over the session to you, sir.
Sure. Thanks for the kind introduction. And before starting my talk, I would like to congratulate Medusane on completing 5 years. It is a humongous achievement. And as your motto says, making medical knowledge, medical teaching accessible to all. It is very important in this day and age. So the topic given to me today is arterial blood gas interpretation. So this all takes me back to my internship, when the major task which was given to us was to collect an ABG, and interpretation was only secondary. So our main job during internship was ABG collection, whether it was for diabetic patients or ICU patients, snake bite patients, etc. So I'll keep it brief and I'll try to make you understand how to interpret an ABG. Basically, whenever we are talking about ABG, it's a very important tool in analysis. Firstly, it is an analyzing machine which is not that costly. It can be used by everyone. Even a basic ICU setup requires an ABG. And there are a lot of diagnoses which you can make from an ABG. And you can even use the ABG for prognostication of the patient, how the patient is improving, whether the patient is worsening, whether the patient is going into septic shock or something like that. And ABG itself can clinch a diagnosis of breathlessness in many patients. And it is always important, it is a good clinical tool to differentiate between a respiratory cause of breathlessness or a metabolic cause of breathlessness. So without further ado, I'm going into the topic. So basically, outlines of presentation, I'll be initially talking about some of the basics of ABG. Some of the mistakes that normally happen that while collecting ABG, especially when you are in the initial phase, even the interns or the nursing staff, is that many a times they take a VBG instead of an ABG. Now, in this talk, I will but it's not possible to discard the VBG as well, because every time you're pricking the patient, ABG is kind of a painful procedure. It's not like your normal blood collection. So I will also teach you what are the normal values normally in a venous blood gas analysis as well. Then you can look at the errors, a bit of physiology. Then we'll go into the basis of acid-base balance, how to basically interpret an ABG, and at the end I'll give you some examples and some drawbacks of arterial blood gas analysis. So basically, there are studies which have shown that venous pH can safely replace arterial pH in the initial evaluation of patients in emergency department. So basically what they mean to say is, when a patient comes to you in the emergency department, the patient might be tachypneic, he will be breathless. So sometimes if you are not skilled enough, you might not be able to get an ABG, as I told you a few minutes back. Then you might be taking a VBG. Now, can VBG be used as a basic of analysis like an ABG? So that is what the study was told. So basically, if you look at a VBG and an ABG, in VBG, your pH will be increased by approximately 0.04, whereas an ABG, your pH will be decreased. And VBGs normally have a higher PCO2 level compared to your ABG reports. So that is one baseline which you have to see. So if you are looking at a VBG PCO2 greater than 45 millimeters of mercury has 100% sensitivity for predicting arterial hypercarbia. But whereas for arterial blood gas analysis, we normally use a cutoff of 40. And similarly, for pH can also be used. VBG is less painful to the patient, but always the gold standard is ABG. Sometimes if you are getting a VBG and you are forced to interpret because you can't prick the patient again, just make sure that you keep this in mind. A VBG has a higher PCO2 level and pH is always on the higher side. Now, what are the sources of error of an ABG? So basically, when you're talking about ABG, initially there is something which we should always do. There is something which we call as an Allen's test. So Allen's test is something which is important while we are interpreting an ABG. So Allen's test is the test which we do before we start taking an ABG. So Allen's test is basically you look at your radial and ulnar artery and make sure you have good blood flow in your radial artery before pricking and making sure your radial artery is patent so that you can take the blood. And similarly, to make sure your ulnar artery is also patent, supposedly if your radial artery goes into constriction, the ulnar artery can compensate for that. Now, similarly, when you are taking an ABG, you should make sure, basically, you should always use what we call a 2 to 3 ml syringe. Basically, what we have is a 2 ml syringe. So a 2 ml syringe is always better to look for ABG. And before taking an ABG, you have to heparinize. Heparin means you should not take a lot of heparin. Hardly you can take a 0.5 ml of heparin or 0.2 to 0.5 ml of heparin and make sure you just flush the syringe. You shouldn't leave large traces of heparin inside your syringe, because large traces of heparin can make a lot of difference in your ABG values. And after taking the ABG, make sure you are taking out the air bubbles from that. So what happens if your ABG sample has air bubbles? If you have air bubbles, the PO2 will be more because air bubbles contain oxygen and your PCO2 will be less. So that means it will give a falsely high PO2 level even for a hypoxia patient. And secondly, because there is a decrease in PCO2, there is release of H plus from albumin, and in turn calcium is bound to albumin. Therefore, you can get a false metabolic acidosis as well. So just make sure your ABG doesn't have air bubbles. Other things, if it is hypothermia, there will be decrease in PO2 and PCO2. Similarly, if there is a time delay, so basically what we call is whenever you have a ABG, make sure you have an ABG analyzer at your in the ICU itself. If you don't have an ABG analyzer in your ICU, make sure you are transporting your ABG specimen, that is the needle, the capped needle within a ice pack, so that there is not much of a change. Because if there is a time delay in the interpretation of ABG, there can be increase in potassium levels, there can be decrease in sodium levels, and because of the RBC metabolism, the PaO2 will decrease and PCO2 will increase, and the pH increases as the cell uses more of bicarb. So that is what happens if you have a time delay in so just taking an ABG is not important. You should also make sure that uh, it is but we should make sure that we are analyzing the ABG as quickly as possible and preventing it is always better if your ABG analyzer is within your ICU or within your casualty setup. Otherwise, if you are just shifting that to the lab, make sure you are shifting it in a ice pack. And while taking the sample, make sure you just flush the syringe with heparin, leaving behind a trace of only 0.1 to 0.2 ml of heparin at max. Because if there is too much of heparin, there will be acidosis which is there will be a falsely low pH and a false negative metabolic acidosis. Similarly, make sure the sample is devoid of air bubbles, because if there is an air bubble, you will get a falsely elevated PO2 levels, which will in turn make your diagnosis more difficult, and you'll be doing more harm to the patient than good by taking the ABG. And there is hypothermia. This is not that important because all our casualties, ICUs, everything is temperature regulated. Your machine also should be calibrated and temperature regulated. So this effect is less. And make sure you transport the ABG fast, because if you are transporting the ABG late, there can be increase in potassium level due to RBC lysis. There can be hyponatremia, and similarly, you can get a falsely high pH because of decreased bicarbonate levels. Now, coming to excess heparin, as I already told, excess heparin can cause a dilutional decrease in bicarbonate and PCO2. Then, similarly, the recommended dose of heparin should be 0.05 ml of low concentration heparin per ml of blood. So, basically, if you are taking a 2 ml blood sample, you can leave around 0.1 ml of heparin, which is roughly the dead space of the needle. You can flush with heparin, but you have to remove the excess heparin and make sure you have just 0.1 ml of heparin inside your needle, because excess of heparin can give falsely low bicarbonate levels and PCO2 levels, and your diagnosis will be completely gone. Now, what is the concept in physiology? So, according to, if your body has to make a pH which is normal, that is your normal body pH, which we say as 7.35 to 7.45 on an average, if you can take it as 7.4, for this to be maintained, your net acid production should be equal to your net acid elimination. That is how the balance is kept. Now, whenever, as we all know, whenever you have an anaerobic metabolism or even in normal metabolism, the acids are produced. This acid is through intravascular transport, and it is eliminated via the lungs and the kidneys. So basically, the carbon dioxide is eliminated through your lungs. Your bicarbonate is eliminated through your kidneys. Now, you have some buffers inside your body to prevent the large pH fluctuation. And the most important buffer, even for ABG, is your bicarbonate carbon dioxide buffer system. Now, basically here you have the reaction, which is reversible reaction. Carbon dioxide will combine with water to form bicarbonate, sorry, H2CO3, which in turn can disintegrate to produce H plus ion, which is your acid, and bicarb, which is your base. So whenever you have excess acid, there will be increased formation of H2CO3. Whenever you have an excess of base, there will be increase in formation of H2CO3. And depending, this is the most important balance or buffer which is needed to maintain your blood pH within the normal limit. So if someone asks you which is the most important buffer to maintain your ABG, that is your bicarbonate, carbonate, carbon dioxide buffer system. Now, basically you have your pH. You don't needn't remember all the complex calculation. Just remember pH is equal to pKa plus log of bicarb plus carbonic acid. And when you are taking it, you find that whenever you are taking a pH level, your bicarb is always on the x-axis, on the top numerator, and your carbon dioxide comes in the denominator. All other things are not that important, just for theoretical purpose you can know, but just for interpretation of ABG, what you need to know is your carbon dioxide is always on the denominator and your bicarbonate is always on the numerator. Just remember that. That is more than enough. This is just for theoretical knowledge. We don't use this calculation anywhere. Now, coming to how the acid is eliminated, as I told you, there are mainly two pathways in which the acid is eliminated from your body. Within the lungs, it is expired as carbon dioxide, and within the kidney, in the proximal convoluted tubule, there is reabsorption of bicarbonate, and which reacts there. And in distal convoluted tubule, there is excretion of the H plus as a high H2PO4 acid, and it is also excreted in form of NH4 plus. Therefore, in proximal convoluted tubule, basically, if you have a high amount of carbon dioxide in the body, for compensation of that, the proximal convoluted tubule will reabsorb more of bicarbonate. Similarly, your distal convoluted tubule will make sure there is elimination of excess acid either in H2PO4 form or a NH4 plus form. Now, another important channel is your K plus H plus exchange channel. Whenever you have acidemia, there is hyperkalemia because it is opposite to each other. So basically, if you have more H plus in your ions, there will be more K plus in your extracellular fluid. And similarly, whenever you have alkalemia, there will be hypokalemia. So all acid-base disorder can coexist except respiratory acidosis and respiratory alkalosis. Therefore, a patient can have a metabolic plus a respiratory component, but a patient can't have both respiratory acidosis and respiratory alkalosis. So this is very important. So just remember the buffer system. You have your H plus bar carbon dioxide buffer, which is there, your K plus H plus ion, and bicarbs are reabsorbed in your PCT and it is eliminated in your DCT. Your H plus is eliminated in your DCT either in form of NH4 plus or as a H2PO4 plus. All this is important because all this is important when we are talking about compensation. Now coming to terminology. Now, is there any difference between acidosis and acidemia? Acidosis is basically the process. That is, you have a metabolic acidosis, you have a lactic acidosis, etc. Acidemia is when you find it in your ABG report. So whenever you say that patient is in acidosis, it is just a clinical query which you have. But when you are fixing that, or when you have a supportive ABG showing the evidence of low pH, that is when you call acidemia. And similarly, osis is a process and emia is the actual pH of the blood. Similarly, when you have increase in bicarbonate or base or increase in pH, then you can call it a alkalemia. So a patient can be either acidic or alkalemic, but not both. That is also important. Now coming to what is the normal value. So this is important. Your normal pH is between 7.35 to 7.45. For ABG interpretation, we can take it as 7.4. Your normal O2 is between 80 to 600. But normally, if anything is less than 60, we say that it's hypoxia. You have 35 to 45 of carbon dioxide. Average, we take it as 40. And if it is a VBG, the average, we take it as 45. And bicarbonate, you can take the average as around 24. So just remember the normal values. Normal value of pH is 7.35 to 45. Oxygen is 80 to 100. Carbon dioxide is between 35 to 45. And bicarbonate is between 22 to 26. Now, respiratory disorder. So basically, you have two types. One is what you call as acidosis, and second is what you call as alkalosis. Now, supposedly, if your acidosis is happening due to a respiratory cause, it is respiratory acidosis. If it is happening due to a metabolic cause, it's metabolic acidosis. Similarly, if it is happening due to a metabolic or as a respiratory cause, you can call it. So basically, as we all know, as I told you an equation at first, basically in pH, you say, you know that your bicarbonate comes on the top and your CO2 comes in the denominator. So with basic maths, we know whenever the denominator is increased, your pH value should decrease. Therefore, respiratory acidosis means your pH has reduced due to an increase in carbon dioxide. So that is what we call as a respiratory acidosis. And similarly, for your pH to increase due to a respiratory cause, that means your denominator, which is your carbon dioxide, should decrease. So that is what you call as a alkalosis. And when it is happening due to your carbon dioxide levels, that is when you call it a respiratory acidosis or alkalosis. And similarly, when we have a pH, again the same, bicarb by CO2. Now, supposedly, if you have if your pH to reduce, your numerator should reduce. That is, there is a decrease in bicarb in the body. That is when we call as a metabolic acidosis. And similarly, when your pH is increased, that means there will be an increase in bicarbonate. Then you call it a metabolic alkalosis. So anything to do with respiratory, it's due to PCO2 level. If your CO2 level increases, your pH decreases, that is respiratory acidosis. And if your CO2 level decreases and your pH increases, that is a respiratory alkalosis. Similarly, for metabolic, when your bicarb is decreased, your pH will be decreased, then that is called a metabolic acidosis. When your bicarb is increased, your pH will increase, that is called a metabolic alkalosis. So now coming to the steps of acid-base balance. So basically, when you're talking about the steps of acid-base balance, first thing you should look at as pH. Before that, there is some scientific things which I'll be discussing. Secondly, we always look at the PCO2 levels, then we look at the bicarbonate level. So just remember, always first thing should be the pH and PCO2. Now coming to the steps of ABG analysis, firstly you have to check whether your ABG report is valid. So for this you have a Henderson-Hasselbalch, you have a basic equation that is 24 into carbon dioxide by bicarb. So supposedly if you just look at this is your ABG report. Your pH is 7.099. Your carbon dioxide is 49.5. Your PCO2 is 31.3 and bicarb is 9.5. Now from this, you can put this into the equation. 24 into what is the carbon dioxide level here? It is 31.3. That is 24 into 31.3 divided by bicarbonate level. That is 9.5. So you get a H plus value that is 79.07. Now you have something called as a normogram, which is available easily in your net. So just look at the H plus value which you get here. Your H plus value is 79.07. Now when you look at here, a H plus of 79 should roughly correspond to a pH of 7.10. So here if you see your pH is 7.099, which is almost equivalent to 7.10. And if your so that means your ABG is valid. So just remember this formula 24 into carbon dioxide by bicarb. Just put in all your values here. You get a value of H plus. Then after that, what you do is you put it into the chart and look, this chart is available everywhere. You can even stick a chart in your ICU or casualty if needed. And compared to that, you compare the pH with that. And if your pH is almost, it won't be exactly the same value. If it is almost near to your value which you get from the nomogram, that means your ABG report is valid. Now coming to next your step is to check the pH. pH, as I already told, if it's less than 7.35, it is acidemia. And if it is pH is greater than 7.45, there is one alkalosis. Normal pH usually does it, but normal pH does not mean that there is acid-base disorder, because there is something called as compensation, which always works in your body to make sure your pH is within normal limits. But mainly when you get the patient in an emergency, your pH is always either low or high. Now, if your pH is less than 7.35, you call it acidemia. And if your pH is more than 7.45, you call it alkalemia. So that is your first step in ABG interpretation. Now coming to your second step, as I told, you had to look at the PCO2 levels. Now, this is what you call as Rome. All this fancy, this thing is not necessary. If you easily remember the formula which I told you, pH is equal to bicarb by CO2, you know that if your carbon dioxide is increased, your pH will be decreased. That is, your pH and carbon dioxide always moves in the opposite direction. Now, if your pH and the carbon dioxide, now supposedly you have a patient whose pH is increased, but his carbon dioxide level is also increased. That means it is not due to a respiratory cause, because if it was due to a respiratory cause, if his pH increases, his carbon dioxide levels have to decrease. So that is important. So just remember, if your pH and PCO2 are in the opposite direction, that means if your pH is high and your PCO2 is low, or your pH is low and your PCO2 is high, then it is mainly a respiratory pathology. Similarly, if your pH and PCO2 are in the same direction, that is, a pH is increased and your PCO2 is increased, or your pH is decreased and your PCO2 is decreased, that is, it is moving in the same direction, then that is what you call as a metabolic pathology. So respiratory, that is Rome. Respiratory is opposite. Metabolic is on the equal direction. So just remember that is more than enough. If your pH and PCO2 are in the opposite direction, that is a respiratory cause. Now coming to 3, we had to look at the compensation. Now what is compensation? Compensation is mainly what you mean by your body always makes an effort to make your pH normal. Now all this is based on that formula, bicarb by carbon dioxide. Now supposedly if your carbon dioxide levels have increased, to compensate for that, what the body has to do, body will have to increase your bicarbonate levels to compensate for that. Similarly, if your bicarbonate levels have decreased and it is causing a decrease in pH, your body will have to hyperventilate to decrease the carbon dioxide levels to maintain the pH. So that is what happens in cases like a metabolic acidosis or a lactic acidosis or a septic shock, salicylate poisoning, etc. Basically here, because the acidosis is happening because the body is losing bicarb and there is increase in H plus ions within the body. Now to compensate for that, the patient will always hyperventilate. This hyperventilate is to remove the excess carbon dioxide from your body. So that is why if you see a metabolic acidosis patient, most of the times he will have a normal saturation levels and he will be his breathlessness will be out of proportion to his saturation. His saturation will be somewhere between 90 to 95, but his breathlessness will be something more like an SpO2 of 50% or 55%. So why is that? Because this excess H plus ions in your body is activating your brain and that is causing a hyperventilation to make sure excess of carbon dioxide moves from your body to compensate for the bicarb. So basically that's what I told. If you have a metabolic acidosis, that is decrease in bicarbonate in the body, your body will hyperventilate to decrease the PCO2 level. And similarly, if you have metabolic alkalosis, that is there is increase in bicarbonate levels in the body, your body will go into hypoventilation to increase the carbon dioxide levels so that your bicarb levels are compensated. So the compensator mechanism for metabolic alkalosis is relatively poor as compared to others. So that is why it becomes difficult for the patient to come out of metabolic alkalosis. Although the patient might be clinically stable, your pH will be always high. Now, similarly, in respiratory acidosis, as we already know, your carbon dioxide levels are increased. Therefore, to compensate for that, your kidneys will reabsorb more of bicarb and there will be excretion of H plus by the kidneys. Similarly, in respiratory alkalosis, in which there is a decrease in carbon dioxide, there will be a decrease in reabsorption of bicarbonate by the kidneys, and there will be excretion of the H plus by the kidneys. So that is what is important. And many of the respiratory acidosis we normally clear using an NIV support. So basically what is compensation? First is to bring the pH back to normal. Respiratory compensation usually takes time, that is 12 hours to 5 days. Metabolic is relatively rapid. It will be compensated mostly within 24 hours. And all this is done provided you are treating the underlying cause of the patient. If you are not treating the underlying cause of the patient and just treating the ABG, that won't help you. And now if the compensation is not adequate, it is likely that there is some other metabolic abnormality which is present. That is what you call as a mixed disorder. Overcompensation mostly does not occur. Overcompensation is very rare. If your pH is above, now supposedly if your pH was around 7.2, it's a metabolic acidosis patient and his pH has gone to 7.5, that means there is an overcompensation which is occurring, or there is a mixed disorder which is there, a mixed acid-base disorder. Or one thing that can happen is it has gone trying to compensate, but it has created a overcompensation, which is physiologically not possible. Now coming to step 4. Now basically there are two approaches which are there to know whether the compensation is adequate. That is, one is the Boston approach and other is the Copenhagen approach. Copenhagen approach is based on standard base excess. I'll be discussing the Boston approach, which is mainly bicarbonate based. It is commonly used, easy to use, and contains a 6 bicarbonate based bedside rules for compensation. So just remember there are two types of compensatory approach. One is Boston approach, which is based on your bicarbonate levels, and second is your Copenhagen approach, which is based on your standard base excess levels. Now formulae, basically this is what you call as winter formulae. For metabolic acidosis, if your metabolic acidosis means your bicarb levels are reduced. So for that, the compensation or the adequate level of carbon dioxide can be measured using the formula 1.5 into bicarbonate plus 8 plus or minus 2. So supposedly if your bicarb was 10, that is the patient is in metabolic acidosis, your PCO2 level should be 1.5 into 10 plus 8 plus or minus 2. So that means if you take 1.5 into 10 plus 8 That is 15 plus 8, 23. Now your bicarb plus or minus 2. That means your bicarbonate level should be between 21 to 25. Sorry, your PCO2 levels should be between 21 to 25 to say that it is compensated. And similarly for metabolic alkalosis, there is another formula in which you have 0.7 into bicarb minus 24 plus or minus 40.2. Now supposedly if you see your bicarb levels are 30. Okay. Now your PCO2 level should be 0.7 into 30 minus 24, that is 6 plus 40 plus or minus 2. Okay, so that is 0.7 into 6 plus 40, that is 4.2 plus 40, which comes up to 44.2. Now plus or minus 2, that is your carbon dioxide level should be somewhere between 42.2 to 46.2. So just remember these two formula. For metabolic acidosis, you have inter formula in which your expected carbon dioxide level is equal to this one. And for metabolic alkalosis, your expected carbon dioxide level should be 0.7 into bicarb minus 24 plus 40 plus or minus 2. This plus or minus 2 is a range, that is minus 2 with then your value comes in between plus 2. Similarly, Winter's formula. Then for respiratory acidosis, a history of the patient is always important. You have to look whether it's an acute condition or it's an acute breathlessness, or if he's a chronic patient like a COPD patient or a ILD patient, etc. For acute cases, every decrease in bicarb increases by 1 for every 10 carbon dioxide above 40. So supposedly if your carbon dioxide level is 30, that is 70 minus 40, that is almost 30. So your bicarb should, for every 10, your bicarb should increase by 1. Therefore, it comes up to your bicarb should increase by a point of 3. But if it's a chronic condition, your bicarb should increase by 4. Now, supposedly, if you see a COPD patient who is a chronic COPD and his PCO2 is 8. Now, how much is 80 minus 40? That is 80 is 40 plus above 40, right? So that is 40. Now, for each 10, if it's a chronic condition, your bicarb should increase by 4. Okay. So when it is 40, your bicarb should increase by 4 into 4. That is equal to 16. Therefore, there should be an increase in bicarb by 16 if it's a chronic condition. Similarly, if it's a respiratory alkalosis, your bicarb should decrease by 2 for every 10. If it's a chronic condition, your bicarb should decrease by 5 for every 10. Just remember the 1, 4, 2, 5 rule. 1 is for acute respiratory acidosis. Your bicarb should increase by 1 point for every 10 points above 40. Now, 4 means in a chronic condition, your bicarb should increase by 4 for every 10 PCO2 level increase. In respiratory alkalosis, your bicarb should decrease by 2. And for chronic condition, your bicarb should increase by 5. All this will be clear when I show you the examples at the end. Now, coming to that. Now, your next step is you have something called as anion gap. Now, what is anion gap? Anion gap, as we know, it's a difference between your measured cations and your measured anions. And similarly, your anion gap formula comes as sodium minus bicarbonate plus chloride. Now, this anion gap is important in case of metabolic acidosis. Now, in metabolic acidosis, when we are saying there are two types of metabolic acidosis which are there. One is a high anion gap metabolic acidosis, which we call as HAGMA, or a NAGMA, which is a normal anion gap metabolic acidosis. Now, why is this important? The causes of high anion gap metabolic acidosis and the causes of normal anion gap metabolic acidosis is different. So that is why this is very important while we are looking at the anion gap of the patient. Now, why potassium? Now, we know that the normal ions, which we normally say sodium and potassium are the ions which we say. Now, why is sodium not considered as a positive cation here? Maybe because the absolute contribution to changes is potassium is so small that it can be neglected. And inclusion of potassium is variable in literature and this does not affect the interpretation of your data in most places. So this is important. So anion gap is important in your metabolic acidosis. So basically you have normal ions. So normal, you have unmeasured anions and unmeasured cation. Then you have a normal anion gap metabolic acidosis where your anion gap is within normal limit. Then you have a high anion gap metabolic acidosis where your normal anion, your anion gap is increased. So if you see here, in the level of potassium, there is not much of a variation from a normal anion gap to a high anion gap. But if you see here, if you see your it's coming here, chloride levels are 104. Therefore, 104 plus 12 comes up to 116. 140 minus 116 is 24. Here, if you see your 118, 140 minus 118 is 22. So this is a normal anion gap metabolic acidosis. This is the high anion gap metabolic acidosis. So why is it important? High anion gap metabolic acidosis, your causes can be due to various other things. This is not that important. Basically, high anion gap metabolic acidosis. So when do you get a high anion gap? High anion gap is mostly seen in a high anion gap metabolic acidosis, whereas a low anion gap is usually in case of hypoalbuminemia, or if he has a hypercalcemia or a lithium chloride intoxication. So just remember, high anion gap is always seen in high anion gap metabolic acidosis, whereas a low or hyperalbuminemia. Now, what is the importance of albumin and phosphate? I'll tell you. And high anion gap can also be seen in metabolic alkalosis. A low anion gap is mainly seen in hypoalbuminemia. Now, why is it important? You should always do an albumin correction. Now, albumin is the main contributor of anion gap. So, if there is a reduction in albumin, then the anion gap baseline has to be adjusted properly. So, if you have low albumin in your patient, you get a falsely low anion gap. So, for that, you correct albumin. You have a albumin corrected anion gap as well. Basically, you measure the anion gap plus 2.4 into 4 minus albumin. Therefore, that is important. Your calcium levels can also be adjusted with this formula, but just remember the correction of your anion gap, because anion gap is dependent on your albumin. If your albumin is low, you get a falsely low anion gap. Therefore, albumin correction is important. Similarly, if you have hypercalcemia, you get a falsely high anion gap, and if you have falsely low anion gap. So just remember, you measure all this when necessary. Then you have something called as osmolar gap. So that is the difference between the serum osmolality and the calculated serum osmolality. Now the calculated serum osmolality comes in this formula, that is 2 into sodium blood plus your urea by 2.8 plus glucose by 18, and your normal osmolar gap is between minus 10 to plus 10. Now, what are the causes of a high osmolality? Ethanol, toxic agent, advanced CKD, and pseudohyponatremia. This is not that important while calculating. All these goes into complex acid-base disorders, which won't be necessary at your level. But just remember, there is something called as a osmolar gap, which is there. Then you have something called as a delta-delta ratio. I told you there can be a coexistence of both metabolic as well as a respiratory component. That is, there can be a mixed acid base imbalance. So supposedly, if you do something called as delta ratio, this is just for your clinical knowledge. Delta ratio is the difference of delta anion gap by delta bicarb. That is your anion gap measured by your anion gap normal. Your normal anion gap is taken as 12 by your bicarb normal by bicarb measured, that is 24. Your 24 is a normal bicarb minus bicarb measured. So this gives you a something called as a delta ratio. If your delta ratio is less than 0.4, then it's a pure normal anion gap metabolic acidosis. If it is between 0.4 to 0.8, it's a combination of a high anion gap metabolic acidosis plus a normal anion gap metabolic acidosis. If it is between 0.8 to 2, that is a pure high anion gap metabolic acidosis. Greater than 2, it's a combination of metabolic acidosis plus metabolic acidosis. So one would expect the ratio to be 1 for pure HAGMA, but in reality, this is basically a range of the values. So now the sequence of steps, I will tell you just the basics which are there. As I already told you, what is the first step you see? First step is you look at the validity of the ABG. That is depending on your H plus, which you get from the formula and comparing with normal gram. Then you look at the pH and the PCO2 of the patient. If the pH and PCO2 are going in the opposite direction, what did I tell you? It is a respiratory disorder. If it is in the same direction, it is a metabolic disorder. Then you look at the third step is you look at the compensation. Compensation, as I told you, if your bike, you have your winter formula, which is there, that is 1.4 into bicarb and 1.8 into bicarb. And similarly, you have your respiratory compensation, in which if it's an acute condition, for every 10 mm increase in carbon dioxide, your bicarb should increase by 1. If it's a chronic condition, your bicarb could increase by 4. And coming to alkalosis, it is 3 and 5. Now you will understand all this when we are doing the questions. Now after that, what you call is, if you get a metabolic acidosis, then you do the anion gap to differentiate between high anion gap metabolic acidosis and a normal anion gap metabolic acidosis. Then if there is an albumin, you can do an albumin correction also here to prevent falsely low anion gap. Then you do something called as a delta ratio, just to know whether there is a mixed disorder or whether it's a pure metabolic acidosis, pure high anion gap metabolic acidosis. Just remember that normally if it is between 1 to 2, it is a normal anion gap metabolic. It is just a high anion gap metabolic acidosis. Now, this is easy. As we told, if your PCO2 is high and if your bicarb is high and your anion gap is normal, it's a combination of respiratory acidosis plus metabolic alkalosis. That is, in respiratory acidosis, what happens? Your PCO2 increases. Now, if your bicarb is also increased and your anion gap is normal, that's a mixed disorder. All this I'll discuss when we are taking the cases. Now, individual acid-base disorder, this is the most important for you. What are the causes of normal anion gap metabolic acidosis? Dehydration, diarrhea, there is volume expansion with NS, there is renal loss, etc. High anion gap metabolic acidosis, the most common causes are lactic acidosis, diabetic ketoacidosis, or starvation. Then you have toxins like your methanol, salicylate, propylene glycol, and even in renal failure and even in septic shock, we get it. Now, CKD, the problem with CKD is initially when you are renal tubular acidosis, you get a normal anion gap metabolic acidosis. But in the later phases, it goes into a high anion gap metabolic acidosis because there is a decline in GFR, which is raising the anion gap by retention of phosphate, sulfate, urate, and hippurate. For you easy, for whenever you're talking about metabolic acidosis, the most common causes are DKA, lactic acidosis, your alcoholic acidosis, your salicylate poisoning, propylene glycol poisoning, renal tubular acidosis. Just always remember, whenever there is a GI bicarb loss due to diarrhea, it's normally a normal anion gap metabolic acidosis. Early CKD, it's a normal anion gap metabolic acidosis. Later CKD, it goes to a high anion gap metabolic acidosis. And DKA is almost always a high anion gap metabolic acidosis. Only thing is, in DKA, when you are treating the patients with IV fluids or volume expansion with NS, this high anion gap metabolic acidosis can move into a normal anion gap metabolic acidosis. But for your UG knowledge, this is more than enough that you get a high anion gap metabolic acidosis in DKA, salicylate poisoning, etc. And you get a normal anion gap metabolic acidosis in early CKD, renal tubular acidosis, or if there's a GI bicarb loss. Now, normal anion gap metabolic acidosis, as I already told you, the most common cause is diarrhea. You need to know the mechanism as such. Then there is renal tubular acidosis, which can cause a normal anion gap metabolic acidosis. Now, coming to metabolic alkalosis, that is what happens in metabolic alkalosis. Your pH is increased due to increase in bicarb within your body. The most common cause of metabolic alkalosis is basically hypokalemia, chloride deficiency, volume deficiency, and hypokalemia due to hyperaldosteronism. So this can be normally, the thing is, this is normally corrected quickly by renal bicarbonate excretion. Therefore, other factors are always required. So whenever there is a failure to eliminate bicarbonate from the kidneys, from extracellular fluid, that is when you get a metabolic alkalosis. And it mainly happens when there is hypokalemia, volume deficiency, chloride deficiency, usually in combination with reduced EGFR, and hypokalemia due to a cause like hyperaldosteronism. Now, coming to causes of metabolic alkalosis, that is increase in bicarb, it can be due to loss of H plus like vomiting, nasosuction, etc. Renal, because you are giving loop or thiazide diuretics. This loop or thiazide diuretics causes what you call, what does it cause? It causes hypokalemia. This hypokalemia can cause metabolic alkalosis. Similarly, a mineralocorticoid excess also because it causes hypokalemia. Then you have Gitterman syndrome, alkalosis, etc., in which there is a gain of bicarb. But for your this thing, your important one is vomiting, your thiazide diuretics, and mineralocorticoid excess. Because there are a lot of patients who are on Lasix or diuretics, you can see that they go into a metabolic alkalosis. Now, respiratory acidosis, as I told, there is increase in PCO2 within your body. It is mainly caused due to COPD. Or you can have neuromuscular disorders in which your carbon dioxide elimination is poor, like your thoracic cage, NMDs, muscular dystrophies, etc. And similarly, if the patient is on sedatives, or if he has a CVA, or if he has a brainstem disease or hypothyroidism, there is increased PCO2 within your body, which can cause a respiratory acidosis. And increased CO2 production can occur rarely in fever, thyrotoxicosis, and later stage of sepsis as well. And even in condition like CCF, in later stages, you can get a respiratory acidosis. And similarly, coming to respiratory alkalosis, you can always look for other causes of hypoxemia as well. But the most common cause of respiratory alkalosis is usually a medication induced or hyperventilation due to stress, anxiety, etc. But always root out pulmonary thromboembolism, which can cause hyperventilation even in the absence of hypoxemia. Therefore, the most common cause of respiratory alkalosis is what you call as hyperventilation, or if the patient has a severe pneumonia or something like that, which is causing the patient to be tachypneic, and your anxiety disorders. Okay, so this is the basic things which are there. Now, alveolar gas equation, all that is not needed. AA gradient is not needed at this point of view. Now, we'll go into some examples. So, this is the basics of ABG which are there. I am not discussed everything in detail going into complex ABGs and to find out what the reason for that, because that takes a lot of time and you needn't necessarily know all those things because many of those are rare causes. Now, coming to take this example, the patient has a pH of 7.30, your PCO2 is 55, your bicarb is 9. Now, first step, what should we do? You should check the validity of the ABG. So for validity testing, you put 22 into 55 by your carbon dioxide level is 55 by 29, you get 45.5. Now, if you look at the normogram, it roughly corresponds to a pH of 7.35. Therefore, your ABG is valid. Your second step, what did I tell you? You look at the pH levels and carbon dioxide level. Here you see that the pH is decreased, your PCO2 is increased. That means your pH and PCO2 are going in the opposite direction. So what does that convey? That means it is a respiratory cause. Now coming to the so pH is low, that is acidemia. Your pH and PCO2 are in the opposite direction, that is respiratory acidosis. Now on clinical history of the patient, it was found that he is a non-case of COPD since 5 years. Now why is this important? That means it is a chronic condition and you should look for chronic compensation, whether it is compensated or not. Now, for chronic compensation of respiratory acidosis, as I told you, for every 10 increase in PCO2, your bicarb should PCO2, your bicarb should increase by 4. Therefore, here if you see your PCO2 is 55, that is your carbon dioxide has increased. If you take your normal as 40, your carbon dioxide has increased by 15. Therefore, for 10, your bicarb should increase by 4. And here if you see it is a half of that, that is 6. Therefore, your bicarb, if you take the normal value as 24, 24 plus 6, that it comes up to 30. So your bicarb should be at least 30. So compensation as it is chronic, bicarb should be 24 plus 4 into 55 minus 40. If you say your 55 is your carbon dioxide level, 40 is your normal carbon dioxide level, divide by 10, because for every 4, your carbon dioxide should increase by, your bicarb should increase by, for every 10 increase from your baseline of 10, your bicarb should increase by 4. Therefore, you see as 30. So here your bicarb is almost equivalent to 30. That means it is the compensated respiratory acidosis due to COPD. Your pH is not yet normalized because it will take some time for your bicarb. When the bicarb reaches 30, then your pH will be almost normalized. And in chronic condition, it will take a longer time to compensate. Now coming to second example, here your first step is look at the validity of ABG. Here the formula has been put in, it corresponds to pH, it is a valid ABG. Your second step will be to look at the pH and PCO2 levels. Your pH is decreased, that means it is acidosis. Your PCO2 level is also decreased, that means your pH and PCO2 are moving in the same direction. Now, when the pH and PCO2 are moving in the same direction, we know that it is mainly what you call as the cause is not respiratory, it is a metabolic cause. Okay. So here if you see your bicarb is also low, that means it is a metabolic cause. Now you know that it is a metabolic cause. The patient is post cardiac arrest. That is mostly a case of sepsis. Now, if it is a metabolic cause, as I told you, for compensation, your bicarb is reduced, your CO2 should also reduce. Now, we know the winter formula in which your compensation is 1.5 into bicarb plus 8 plus or minus 2. That is 1.5 into your bicarb level here is 12 plus 8 plus or minus 2. That is 1.5 into 12. That is approximately this value will come between 24 to 28. Here what is your PCO2 level here? 28. Now this is a compensated metabolic acidosis because your carbon dioxide level has almost reached the bicarb levels. It will take time for the pH to be completely normal. So this is a compensated metabolic acidosis, mostly a lactic acidosis post CPR. Okay. Coming to the third example, here if you see, we look at the pH, validity, just leave it. This is a 75-year-old patient. There is history also here. He's a female, fever and shortness of breath. Respiratory rate is 35. That is, it is increased. Your BP is low. There is hypotension. Your saturation is low. That is, there is hypoxia. And your chest X-ray is showing pneumonia. So you have a background history of a pneumonic patient with high respiratory rate and you have hypotension. This hypotension is likely secondary to sepsis. Now, you did an ABG of the patient. You found that your pH, leave the validity part here. Your pH is high. That means it is a alkalemia, right? Now, when your pH is high, then second part is you look at the PCO2 level. PCO2 is low. So your pH and PCO2 are moving in the opposite direction. Therefore, it is what you call as a respiratory alkalosis. Now, what is the cause of respiratory alkalosis here? It is mainly a pneumonia which has caused hypoxia and the patient has a high respiratory rate which is causing tachypnea and increased POCO2 washout from the body. So there is a decrease in PCO2 within the body. Now to compensate for that, there should be a decrease in bicarb. They have given the albumin values, they have given the chloride values, they have given the potassium values, but you normally needn't go into all this. So here if you see, your validity is there, pH is alkalemia we discussed, PCO2 is low, it is moving in the opposite direction, respiratory alkalosis. Now if you put into the compensation formula, you find that your expected bicarb is 21. Okay, but here if you see, your bicarb level is 17. That is, it is lower than what is needed. That means there is a coexisting metabolic acidosis as well. So earlier when we discussed a point, we always discussed that rarely there can be overcompensation or rarely there can be a increase in pH. So here it is a combination of both your respiratory acidosis as well as metabolic acidosis. I hope you understood because for compensation level, your bicarb levels required are only between 21 to 24 when you put in the formula. But here your bicarb levels are way below that. That means there is a coexisting respiratory metabolic acidosis. Now, supposedly, if your bicarb levels were way higher, 28, that means there is a coexisting metabolic alkalosis. When you progress with the other things, you look at the anion gap with the sodium and your bicarb plus chloride formula, you find that there is a anion gap of 24, which is high because your normal anion gap is 12, and you find that there is a high anion gap metabolic acidosis. Now, why is this high anion gap metabolic acidosis? Secondary due to a lactic acidosis. So here, if you look at just the respiratory alkalosis, you would have gone into a diagnosis only of pneumonia. But here you see that there is a lactic acidosis, which means that the patient is in sepsis. Sepsis is causing lactic acidosis. Therefore, there is a coexist in this thing. So anion gap ratio also I told you, that is sodium minus chloride plus bicarb. So your sodium here is 148. Your chloride is 110 plus 17, that is 21. And why is corrected anion gap 24? Here they have corrected it for the albumin level as well, because there is mild hypoproteinemia which is there. So you have a combination of both your metabolic alkalosis as well as your, respiratory alkalosis as well as a metabolic acidosis. Now this is another patient, 61-year-old male patient, morbid obesity, COPD, CHF. That means he is a chronic respiratory patient. Okay, because yes, COPD and CHF. Here, if you look at the validity of the ABG is done. Here, if you look, your pH is 7.41. That is, pH is within the normal limits. PCO2 is 55. That is, PCO2 is high. And your bicarb is 34. That is, your bicarb is also high. Now, if you see here, his PCO2 is 50. So he is a chronic condition. And if you're taking 40 as the base, that means his PCO2 is increased by 15 from the baseline. Therefore, because it's a chronic condition, your bicarb should increase by 4 plus 2. That is equal to 6. So if you are taking 24 as your normal bicarb levels, 24 plus 6 should come up to 30. Only 30 is needed. But here, if you see, your bicarb is more than 30. That is, it is 34. Therefore, here it is most likely to be a respiratory acidosis plus maybe a metabolic alkalosis. We'll look into the interpretation. So that is how we go about it, right? So here, if you see, pH is normal, PCO2 is elevated, that is, there is a respiratory acidosis. Now, compensation, opposite disorder must be present, that is, you get a metabolic alkalosis. So, your anion gap is normal, that is, metabolic acidosis is ruled out. So, you get a combination of respiratory acidosis plus a metabolic alkalosis. Now, why did this happen? Respiratory acidosis is due to COPD, and alkalosis is mostly due to a hypokalemia. Here, if you see, hypokalemia, which is caused due to a diuretics because the patient is on CHF. So this is a heart failure patient. So this is why your history taking is very, very important. So what started off as a respiratory acidosis here progressed to a metabolic alkalosis due to diuretic because your potassium was eliminated and there was increase in pH of the patient. Now coming to an example 5, here also you have a history, 32-year-old patient, vomiting since 4 days, you have a tachycardia and hypotension. If you look at the pH, pH is within normal limits. Okay. PCO2 levels, if you take 40 as baseline, it is slightly raised. Bicarb levels, if you take 24 as baseline, it is slightly raised. Potassium levels are reduced. Chloride levels are reduced. Sodium levels are normal. Now here we have a pH normal, PCO2 slightly high, that is 42. Bicarb is slightly high by 2. Now supposedly, because your pH is high and PCO2 is high, that is, they are mostly in the opposite direction, right? I mean, it is in the same direction. Therefore, it is not due to a respiratory cause. Here your pH is within normal and your bicarb is a bit high. That is, it is mostly due to a metabolic cause. Okay. So here if you see, your pH is normal, your PCO2 is almost normal. There is no compensation. But if you look the anion gap, your anion gap is more. That is, there is a high anion gap metabolic acidosis. And if you look at the delta ratio, there is metabolic alkalosis. So this is kind of complicated for you people. This is not necessary. I told you the basic things which are needed. That is more than important. That is more than necessary. This is a bit of a complicated case in which we had to, because there is a combination of all that, and we have to always look at the patient profile when needed. So what are the drawbacks of ABG? Pulse oximetry is always a better measure of tissue oxygenation. Checking AA gradient may be misleading in the ICU. And similarly, your pulse ox always gives a better result compared to your ABG of your PO2 levels. And it's a painful and invasive procedure. And some amount of skill is needed to take the ABG so that you get a proper arterial blood gas sample. So this is what is important. This is what I want you to know in summary. Step is first is validity, second is pH, third is look at PCO2, whether pH and PCO2 and the opposite direction, that means it's a respiratory cause. If it's in the same direction, look for a metabolic cause. If it is a respiratory cause, look for compensation. If you go into a metabolic cause, you look for anion gap to differentiate between a high anion gap metabolic acidosis and a normal anion gap metabolic acidosis. Then you look at the delta ratio. Just know about delta ratio to look at whether it's a normal anion gap plus high anion gap or just a pure high anion gap metabolic acidosis. Then you have to look at the differential diagnosis of the patient. This oxygenation part is not that necessary for you right now. So I hope I have made everything clear. I'll just give you a few points which are necessary. Firstly, while collecting ABG, there should be no air bubble. If there is an air bubble, what will happen? If there is air bubble, there will be increase in PO2 level and falsely high. Make sure heparin is hardly 0.1 ml. Excess heparin, there will be increased bicarb. And make sure transportation is done quickly, because if transportation or analysis is not done quickly, there can be falsely high hyperkalemia. Okay, so that is the basis of ABG. You can use the radial artery, your popliteal artery, radial artery, your brachial artery, and even your femoral artery if possible. All right. Now, the main buffer in your body is H plus bicarb or the bicarb CO2 buffer. Bicarb is reabsorbed in the PCT. H plus excreted in the DCT. Okay. And causes metabolic acidosis. There are two types. One is high anion gap, normal anion gap. High anion gap is the most important is DKA, sepsis, late CKD. Normal anion gap, you have your renal tubular acidosis, and sometimes may be due to H plus loss due to vomiting. Then metabolic alkalosis, that is due to bicarb loss or due to hypokalemia, which is mainly secondary to diuretics, or you can have a hyperaldosteronism or a mineralocorticoid excess within your body. The most common cause of metabolic alkalosis, which I have seen, is hypokalemia, secondary to diuretic use. Now coming to respiratory causes, you have respiratory acidosis, and the most common cause is COPD, chronic heart failure, interstitial lung diseases, neuromuscular diseases, use of sedative hypnotics, or if the patient has a CVA or stroke. And similarly, when you're coming to respiratory alkalosis, it's most commonly due to hyperventilation, which can occur due to anxiety, or if the patient has a pneumonia, etc. Always look for compensation. And if your compensation values are a bit high, that is if your expected bicarb is 20, but your bicarb coming is 24, make sure that to look for other mixed disorders by looking at the anion gap and other things. Okay. So most of the ABGs which you get in exams will be just a clear-cut ABG, but sometimes there can be a mixture of both. So make sure you are taking into consideration all those things. I hope you understood some of the basics which I wanted to tell you. Some of the other things are higher level which you need to know at this point in time. Normally during your PG or your critical care posting, you'll get more of that. But just remember the basics which are necessary, and just remember the compensation formulas which I told you. Okay. So that is more than enough for you all these things. So this is the other mixed disorders which can have, as you told, as I told you, there can be normal a lot of things which can happen. You can take a photo of this and try memorizing it, but all this will make your basic understanding more complicated. These are high-end levels which mostly are discussed during post-graduation days and other things. And these are only basic critical care patients who can have who are on lot of medications and who can have a combination of lot of other things. Okay, so I'll end it here. Thank you.
Sir, with this, thank you so much, sir, for joining with us today. It was really a wonderful session. Sir, I have sent you a WhatsApp regarding the quiz finalist of Medmemorate 2025,
All right.
which we have prelims, which we have conducted in the morning. So
All right.
it will be a great honor that if you announce the finalist of the Medmemorate Cardio Quiz 2025.
Okay, just 1 second.
Yes, sir.
Okay, so I have got the results. The quiz was held today morning, right?
Yes, sir.
Okay, so these are the finalists, right? So these are the finalists of the quiz. So I'll be announcing the uh, results. So first one is Taki twins, that is Yashaswini Suman and Supreet Ranjan from ESIC Medical College Hospital, Patna, Bihar. The other team is Breathing Scrubs, that is Sriram Babu and S. Pavan Keshav from Madurai Medical College. Then we have Takotsubo Titans, that is Yash Ratwani and Om Shah, BJMC Ahmedabad. Dextrocardia, Havra Patanwala and Kunika Patel from State GSMC, mostly Mumbai, I guess. Then you have academic assassins, that is Gayatri KR and Ashwika G from Savita Medical College. Then you have heart attack, that is Rashmika Chand and Ananya Sharma from KMC Manipal. I'll announce once more. First is Taki twins, Yashaswini Suman and Supreet Ranjan from ESIC Medical College Hospital, Bihar. Second is breathing scrubs, that is Sriram Babu I and Pavan Keshav from Madurai Medical College. Then you have Takotsubo Titans, that is Yash Ratwani and Om Shah from BGMC Ahmedabad. Dextrocardia, that is Havana Patanwala and Kunika Patel from SAGE GSMC. Academic Assassins, Gayatri KR and Ashwika G from Savita Medical College. And Heart Attack, Rashmika Chand and Ananya Sharma from KMC Medical College. So these teams will be going to the finals. Okay, congrats to all the winners. Thank you.
Thank you, sir. Thank you so much. It was really a privilege for your session today and also for you to take time and announce the results of the Cardiac Quest prelims. Cardiac Quest finals will be conducted at the evening today, which will be led by Dr. Karthikeyan, sir, renowned cardiologist from RML, Delhi. Thank you, sir. And Lalitha, you can just proceed with vote of thanks.
Yes, sir, thank you. As we come to the close of today's enlightening session, I, Lalitha M, again taking this opportunity to deliver the vote of thanks on behalf of Medusane team and all the attendees here. First and foremost, a huge thank you to Dr. Athul Francis, sir, for delivering a truly game-changing session on ABG interpretation. Sir, what was once a daunting jumble of numbers for many of us, you transformed it into a logical, approachable, and even exciting clinical tool. From unraveling asset based imbalance to decoding compensation patterns, your step by step explanations and real life correlations made the complex feel conquerable. You reminded us that ABG is not just a set of values, it's a window into a patient's physiology, and when interpreted right, it can literally be life-saving. This session will definitely serve as a cornerstone in our clinical understanding, not just for exams, but for the wards and beyond. To our beloved Dr. Raghunandan sir, the visionary behind Medusane, thank you for creating this platform and bringing us all together under one mission to make medical education engaging, accessible, and inclusive. An immense thanks to Medicine team from the content creators and tech support to coordinators and moderators for your tireless efforts behind the scenes. Your dedication makes every session a smooth and enriching experience. To all the attendees, thank you for showing up with such an enthusiasm and curiosity. It's your presence and participation that breathes life into these learning spaces. Wishing you all sharper minds, stronger concepts, and confident clinical futures ahead. Thank you.
Thank you. Thank you, sir. Thank you so much, sir.